Muy buenas, soy Jorge Alió y os quiero dar la bienvenida a este espacio ARI25, donde esperamos que disfrutéis de las innovaciones en cirugía del segmento anterior, abarcando la córnea, las lentes intraoculares, la cirugía refractiva y finalmente casos clínicos de interés. Vamos a tener como novedad un espacio virtual especialmente dedicado a la industria y a la tecnología, donde podréis visitar a nuestros patrocinadores. Sed bienvenidos a este espacio virtual de innovación, tecnología y progreso científico y profesional que supone ARI 2025. Muchas gracias a todos.
Every new day, the world awakens with countless moments of joy, discovery, and hope. New stories and new memories. As Biotech Healthcare, we are here to enrich these moments, improve quality of lives, help people live better all around the world. We are with them in every moment they look through life, in every moment they mirror their beauty, or as they walk strongly towards their dreams. Our journey was founded on a vision for providing light and visual excellence to all parts of the societies. Established in India in 1999, we've been empowering communities worldwide to access advanced healthcare technology and products. And in less than a quarter century, we've introduced over 50 different products, expanding into 3 different verticals in the medical device industry: ophthalmology, dermatology, orthopedics. Our impact spans across 106 countries, touching millions of lives, selling over 4 million medical devices every year. When it comes to quality, we leave no room for compromise and set the standard high. Our product portfolio ranges from ophthalmic surgical products, IOLs, solutions and accessories, to orthopedics products, single-shot and multi-shot viscosupplement solutions for osteoarthritis, as well as dermal fillers for skin rejuvenation and facial volume restoration. We are one of the world's largest manufacturers of pre-filled syringe-based solutions with a capacity of 10 million syringes per year. Our dedication to innovation knows no limits. With our sales and marketing headquarters in Lucerne, Switzerland, cutting-edge R&D centers in Roscommon, Ireland, and Ahmedabad, India, we deliver medical innovations to more people and places through technology and operational excellence. Behind every milestone, there's a dedicated team of over 750 experts dreaming and innovating for a better world and future. At Biotech Healthcare, we're not just about products. We're about creating the foundation for delightful moments. We're here to enable access to new memories, discoveries, stories, and happiness. We are here to enable access to innovation.
Hello, we are now in session 11 of ARI 2025, and we're going to deal about this most interesting and always important topic about how to manage glaucoma by the cataract surgeon. And I'm happy and I'm very thanks to have to chair this session with José María Martínez de la Casa. He's in Madrid and he will be connected now, and he will be with us accompanying with the keynote of this session, which is the first topic. And the first topic is how much cataract surgeons should expect from cataract surgery in terms of IOP, intraocular pressure decrease. So José María Martínez de la Casa, Professor Martínez de la Casa, you are the first speaker, and tell us about this topic of how much drop in IOP should be expected from cataract surgery. Thank you.
So, hello everyone, and thank you, Professor Alió, for inviting me one year more to participate in this meeting. And my topic today is what effect on intraocular pressure should I expect from cataract surgery in patients with glaucoma. Usually, this is a controversial topic because sometimes we can have a significant reduction of intraocular pressure, but also we can have elevation of intraocular pressure, so it's important for the management of patients with glaucoma. These are my financial disclosures. None of them are related with the content of this presentation. So, the cataract and glaucoma are two diseases that frequently persist in elderly patients. Both diseases can affect the visual function and quality of life. The cataract surgery may influence the intraocular pressure. We can have a significant reduction of intraocular pressure, but also we can have a significant elevation of intraocular pressure. So understanding this effect helps in the surgical plan and the postoperative management. So the first is to talk about the reduction of intraocular pressure after the cataract surgery, which are the mechanism of intraocular pressure reduction after phacoemulsification. Of course, when we remove the lens, we have a deepening of the anterior chamber, we have a widening of the iridocorneal angle, we have a reduction in pupillary block and anterior lens vault. We can have some kind of remodeling of the thoracic meshwork due to the irrigation in the anterior chamber during the surgery, and we can have some possible effect on the US cloud outflow. We can have an increase in the US cloud outflow because we have, with the inflammation induced by the cataract surgery, we can have some kind of release of endogenous prostaglandin that can help to increase this US cloud outflow. So this effect on the reduction of intraocular pressure is different in different types of glaucoma. Of course, the more important reduction in intraocular pressure is achieved in angle closure glaucoma patients with a mean decrease around 30% after 12 years. The second glaucoma that benefit of the removal of the cataract is the espholic glaucoma with a mean decrease of intraocular pressure around 20-25% at 12 months, because usually this patient has a high baseline intraocular pressure, and the intraocular pressure lowering effect is most pronounced in eyes with higher preoperative intraocular pressure. So these patients with espholic glaucoma usually have a significant reduction of intraocular pressure, and the most modest response is in a primary open-angle glaucoma with a mean reduction around 18% at 12 months. But this reduction in intraocular pressure is important to know that it's not forever. Usually this intraocular pressure reduction diminishes over time, and we can see these two graphs from the ocular hypertension treatment study showing that after 1 year after the cataract surgery, the pressure is quite similar in the patients that receive cataract surgery and the control eyes, and we can see a significant difference in the medication reduction. So the pressure numbers are more or less the same after 1 year after the surgery, but we can have some decrease in the medication requirements in these patients after the cataract surgery. But again, it's important to monitor the intraocular pressure after the surgery and adjust the therapy when necessary. As I mentioned, the angle closure is a special type of intraocular pressure when we are talking about the intraocular pressure reduction after the surgery, and it's quite common that we have a significant and sustained reduction of intraocular pressure in patients with angle closure glaucoma, because in this patient we have a widening of the anterior chamber and opening of the angle that improves the aqueous humor outflow. This reduction of intraocular pressure is much more important than in patients with open angle glaucoma, and it's important to know that this effect is more pronounced in patients with early angle closure glaucoma than in patients with moderate or advanced, because in those patients with moderate or advanced angle closure, we can have we have some degree of damage in the angle, and although we remove the lens, we can not achieve as the important reduction that we have in early cases when we have only mild effects in the visual field. In this angle closure glaucoma patients, we can achieve average reduction between 4 and 8 millimeters of mercury, and the EAGLE study demonstrated that the lens extraction, even the clear lens extraction, was superior to the iridotomy in the control of the intraocular pressure. So it's indicated even the clear lens extraction is indicated in patients over 50 years of age, is indicated in patients with primary angle closure glaucoma, and is indicated in patients with angle closure with pressure above 30 millimeters of mercury. Which are the predictors of intraocular pressure reduction in patients with angle closure glaucoma? The higher baseline intraocular pressure, the shallower the anterior chamber depth, the increased lens thickness, and the older age. And as I mentioned, the later the surgery is performed, the smaller the effect on intraocular pressure reduction. I think this paper is really interesting because the authors propose an index to predict the reduction of intraocular pressure after the cataract surgery in patients with angle closure glaucoma. This index is called pressure to depth ratio and relates the preoperative intraocular pressure with the preoperative anterior chamber depth. And the authors conclude that when this index is higher than 6, the reduction is really important. Reduction of intraocular pressure is really important, around 5 millimeters of mercury. When this index is lower than 6 millimeters of mercury, the reduction it's much lower. So you can see that in 100% of the patients with this index higher above 7, the reduction was always higher than 4 millimeters of mercury. This other paper published this year also defined the predictors of intraocular pressure reduction in patients with angle closure glaucoma, which was the baseline intraocular pressure, the anterior chamber depth, and the lens thickness, and also the authors can calculate more or less the reduction of intraocular pressure based in these three factors. But not always we achieve intraocular pressure reduction after the cataract surgery. We can have also significant pressure spikes after the surgery, and it's important to note the IRIS registry showed that a significant pressure spike defined as higher than 30 millimeter pressure, higher than 30 millimeters of mercury, an elevation of 10 millimeters of mercury from baseline occur in 3% of the eyes, and it's more frequent in patients with glaucoma than in patients without glaucoma. And most spikes occur within the first hours, and in most of them are solved without any treatment in 24 and 48 hours. So, but it's important to know, and it's important to see that in patients with glaucoma, these pressure spikes can be important. The study showed that there's no difference in pressure spikes between the conventional phacoemulsification and the femtosecond-assisted cataract surgery. The risk factor for this elevation of intraocular pressure were the high baseline intraocular pressure, again, the male sex, the glaucoma of any type, the older age, the black race, the use of more preoperative intraocular pressure lower medication, and the tamsulosin use, probably because it's a more complex surgery than in patients that don't use the tamsulosin. Also, some risk factor related with the cataract. The surgery classified as complex, the retention of viscoelastic in the anterior chamber. Overall, if we have used dispersive viscoelastic, the greater energy delivered and the surgical experience, so the less experienced surgeons have a higher risk of pressure elevation of intraocular pressure after the surgery. And also risk factor related with the type of glaucoma. The glaucomas with high risk of pressure spikes were the exfoliative glaucoma and the pigmentary glaucoma, and the protective factors were the angle closure glaucoma and the diabetes with an unknown mechanism. The prophylaxis of these intraocular pressure spikes after the surgery is indicated in patients that before the cataract surgery has a pressure higher than 20 millimeters of mercury, those patients with non-glaucoma, and those patients that it has complicated surgery. And we can use a beta blocker fixed combination without prostaglandins, of course, and the oral acetazolamide, depending on how we predict that there is these pressure spikes. And the treatment, if we have an elevation of intraocular pressure higher than 30 millimeters of mercury or a rise of 10 millimeters above baseline intraocular pressure, again with a topical beta blocker with a fixed combination without prostaglandin or oral acetazolamide. And of course, in those patients with severe cases or severe elevation of intraocular pressure, we have to monitor the intraocular pressure during the first 24 and 1-2 days after the surgery, with reassessment very frequent during these first 2 days. And the surgical treatment is indicated in those patients with very high intraocular pressure, over 40 or 50 millimeters of mercury, with poor response to medical treatment, with viscoelastic in the anterior chamber that has to be removed. Patients with severe glaucoma, where even mild or transient intraocular pressure elevation can accelerate progression, and those patients with severe corneal edema, pain, nausea, or early optic ischemia. And then the type of surgery depends on what is the cause. The paracentesis, the anterior chamber was out of the glaucoma surgery when needed. And it's important to measure the intraocular pressure even in very quiet eyes, because, for example, we had this alert with some intraocular lenses some time ago, and this patient has a very quiet eye, no pain, very mild inflammation, very high intraocular pressure, and they had significant increases in intraocular pressure due to a toxic effect related with the cover of the injector. So it's important to monitor and to measure the intraocular pressure even in patients without any symptom during the first 1 or 2 days after the surgery. So in conclusion, the cataract surgery can produce significantly intraocular pressure reduction in patients with different types of glaucoma. These decreases are often transient, except in early angle closure glaucoma, so patients must be monitored chronically. The elevation of intraocular pressure after cataract surgery are also common in glaucoma patients, and appropriate prophylaxis and treatment of these hypertensive spikes are essential, and they may lead to significant worsening in glaucoma patients. Thank you very much for your attention.
Thank you very much, Jose Maria, and we shall have time at the end to discuss all this information, which is very important. And now, Leon Liu from the United Kingdom will tell us about when to associate mix and which one to cataract surgery. So, Leon, you are the next one.
Thank you very much for the invitation. My name is Leon Au. I'm one of the consultants from Manchester in the UK. So when to associate mix in cataract surgery, and which one? These are my financial disclosure, which involves a lot of the company. So when do you associate mix in cataract surgery? Well, this is the slide for you. In a nutshell, just about every glaucoma patient that's on medication, if you ask me. If you're glaucoma, you're on medication, you're coming for cataract surgery, there's a very strong chance that I would suggest adding a mixed procedure. You don't even have to be on medication. If you are a newly diagnosed glaucoma patient, open angle, and with cataract, then before I even start you on drops, I may even put you straight down for a cataract operation combined with mix to lower your pressure before I consider starting you on eye drops. Classically will be your mild to moderate open angle glaucoma, which is where the mixed procedure tends to be tried and tested. Particularly if your pressure is controlled on meds, then doing the cataract surgery with mix will lower your medication count. But even if your pressure is a bit higher, doing a phaco mix will not only lower your pressure, but also reduce your medication count. The same logic then leads to the ocular hypertensive, which a lot of us would consider doing a phaco mix. However, ironically, this is probably the area that's the most evidence light, because all the mixed trial tends to recruit open angle glaucoma, and ocular hypertensive without any disc damage or field abnormality tends to be excluded in the trial. But nonetheless, we all would consider adding a mixed procedure, but understanding that phaco on its own does tend to lower pressure quite well in the ocular hypertensive. When it comes to angle closure glaucoma is a bit more contentious. Most of the mixed procedure is by definition contraindicated. However, we'll show you a little bit of evidence to suggest that a lot of us are beginning to add a bit of mixed procedure to angle closure patients when it comes to phaco. Advanced glaucoma, again, used to be contraindicated. We're not talking very bad glaucoma progressing that needs trabeculectomy, and in those cases, do a trabeculectomy. But on the other hand, if you've got an advanced glaucoma patient who is reasonably well controlled, but on multiple medications, when I come to do the cataract, I would consider adding a mix to see if I can at least reduce the pressure a bit more or reduce a little bit of medication load. And occasionally when they've got somewhat uncontrolled pressure and cataract, and I'm not particularly happy with doing cataract surgery with trab, a phaco trab, for example, if it's not something that you do regularly, then a lot of us will consider what we call a bridging procedure, where we do the phaco with mix, reduce some of the medication load, hopefully hold the pressure to a reasonable level, allow the conjunctiva to settle down a bit, and then 6 months, 9 months, a year later, perform a trabeculectomy. So we may consider a phaco mix as a bridging procedure. I think for me, the only really contraindication, so to speak, where I probably wouldn't bother adding mix is in patient who's got low tension glaucoma. If physiological pressure is already failing you in low tension glaucoma, adding a mix is, in my book, highly unlikely to do anything, because mix is there to enhance physiological outflow. But in low tension glaucoma, you want it to be below physiology, so I tend not to bother adding a mixed procedure. We talked about the mild to moderate. Why do we talk about it? Because there's a randomized controlled trial, at least 3 or 4 with various devices that's already been done to show that adding a mix is beneficial over phaco alone. These are some of the figures. You're adding a mix, you may get an extra 1.5 to 2.3 millimeters of mercury reduction over phaco. Ballpark figure, phaco drop you down by 5, adding a mix may add another 2. And I think that's quite useful in a lot of glaucoma patients. We're more likely to achieve our success criteria when you're defined by over 20% reduction on no medication. And we know that this is one of the HYDROS results, which is the only mixed trial that ran concurrently for 5 years, showing that adding a mix in mild to moderate glaucoma does lower the pressure more than phaco, lasting for 5 years. This is where people say, well, if you're on one medication coming in for phaco, why would I bother adding a mix? Cataract will probably lower your pressure just as good. Well, actually not quite true, because if you take a one meds patient coming in for phaco, this is from the HYDROS trial, if you just do the phaco alone, there's just under 50% chance, 50-50 chance you will come off the medication at 5 years. But if I add HYDROS, the chances for you to be off medication is increased significantly to 70%. So that mix buy you an extra 20% success. And for me, that is something you can tell your patients, and a lot of patients will see that is beneficial, and adding a mix is worth the while. We already have data to show that if you add a mix to your cataract in a mild to moderate patient, they are less likely to need subsequent filtration operation at 5 years. We've demonstrated that adding a mix to phaco, your visual fields is less likely to progress compared to phaco alone. When it comes to angle closure, as I told you before, even then, I think there are at least 2 randomized control trials. This is just one from my friend from Singapore, to show you that if you add a mixed procedure like the iStent to phaco in angle closure, the phaco iStent group did better in terms of success than phaco alone. Wouldn't be surprising when the trabecular meshwork in those angle closure patients are quite damaged. So during surgery after phaco, if you can do something to bypass the meshwork, it's beneficial. You do have to be a little bit careful though, because the angles of these patients are often tight. So you can see that this is a patient that we did a phaco iStent first generation. Although you can get it in, but you see that it sits so close to the iris right here, you can see that the iris is coming up, blocking the device. And with a bigger device still, like the Hydrus, you can see that the device is almost totally blocked. So in angle closure, you kind of have to pick your device a little bit more carefully. Like I said, a bridging procedure is often what we consider an advanced glaucoma. So if you look at this lady who came to see me with that sort of ocular surface on 4 eye drops, advanced glaucoma, no one really would want to be tackling that glaucoma with trabeculectomy. So what I did was a phaco mix, improve the vision, get her off some of the medication, and allow the conjunctiva to recover, and later on, we do a successful trabeculectomy. So this is what we call bridging procedure. Lastly, what procedure to do? Now, really, we don't really have time within this 8 minutes to go through every single procedure. There are stenting procedure and the ripping procedure overall. And I'm going to be completely honest with you, I'm a stenter, it's not a ripper. So for me, the go-to has always been the Hydra stent, which is a device where we insert through the trabecular meshwork into the Schlemm's canal, just as you can see here. And the idea is lower pressure. And we have randomized control trial tells you that the benefit, as I've just mentioned to you before. However, we have now also the iStent, and the iStent's been around for a long time, the Inject, and then it changed to the W, which I prefer with the bigger flange. And I'm particularly impressed with the iStent Infinite that's just come out, which is basically 3 stents. And that have now changed my perception in terms of Hydrus being more powerful than an iStent. And I think beginning that I feel that iStent Inject Infinite is certainly playing in a very much the same league as the other stenting procedure like the Hydrus. So you can see here one surgical video to show you this is the Infinite being implanted. We implant one through the Schlemm's canal, through the trabecular meshwork into Schlemm's canal, one to the left-hand side of it as far away as I can, one to the right-hand side of it as far away as I can. So you can have 3 entry points as far spaced out as you can. The idea is to tap into the collector channels at different parts of the eye within this 5-6 clock hour period, as you can see. Pretty straightforward to do at the end of cataract surgery. And what I want you to see is the position of it need to be precise with the iStent, and then the Hydrus, again, it need to be a little bit more precise into getting it into the canal. And then what I'd like to show you is what we call an intraoperative flow test. You can see that when I put Vision Blue in, you see how the Vision Blue travels through the mixed device into the collector channels. Look at the clock hours we managed to achieve here with an Infinite. 3 stents, we are achieving 6, 7, 8 clock hours of flow. And I think that is the power of having multiple access points. There are ripping procedures that I don't particularly have time to go into, like the Kahoot Dual Blade. You can bend needle to rip it. You can dilate the canal and rip it with the Omni procedure, and you can do it with a canaloplasty, dilate it, and also rip the canal at the same time. And ultimately, and you can also make holes, by the way, using an Elios excimer laser here, as you can see at the end of the phaco. It basically laser and create 10 openings in the trabecular meshwork, as you can see here. Implant-free procedure, is it really preferred? Well, I think this debate continues to be had, but they do lack a little bit of RCT data, and I'm not 100% sure myself in terms of removing meshwork and what good or harm it can do in the long run. It's good to know the stents, for me, are safe, and they are MRI safe as well. And there's always worry about the device causing endothelial cell loss, and I think that's probably a bit of a myth. I think only device that's poorly implanted can cause endothelial cell loss. So ultimately, if you ask me, I think we should associate mix with just about most cataract operation, and which one, very, very personal. And my personal view is that stenting is the best mix to combine with phaco, particularly when the patient they come for the phaco. If you want a good cataract result, some control of glaucoma, stenting is the best mix to add in. Thank you very much.
Thank you very much, Leon. And now is the time of Dr. Cedric Switzer from France. He will talk about which IOLs, intraocular lenses, should I use in glaucoma patients. Very interesting topic, Cedric, so you are the next speaker.
Dear colleagues, thank you very much for your invitation to talk about which lenses can we use for our glaucoma patient. First of all, as you know, cataract and glaucoma are very frequent ocular comorbidities, and this study has analyzed all patients with cataract from the medical database, and has shown that 90% of this cohort of patients also had glaucoma. As you all know, beside the very typical visual field defects we can observe in glaucoma, this meta-analysis has also shown that contrast sensitivity can be observed in glaucoma patients, and dark adaptation and halos can be 2 times more frequent at severe stage of the disease as compared with control patients.
What about toric IOL and glaucoma? So the literature is quite scarce on toric and multifocal IOL, but this retrospective comparative study has included patients with phacoemulsification and ab interno bypass surgery with toric IOL versus control patient with toric IOL. And they showed that there was no significant difference in the cylinder refractive error between the two groups. By comparison, this meta-analysis has compared glaucoma surgery-induced astigmatism between non-penetrating filtering surgery and trabeculectomy. And not surprisingly, they showed that at 6 months, surgically induced astigmatism was significantly more important in the trabeculectomy group as compared with the non-penetrating glaucoma surgery group. What about multifocal IOL and glaucoma? As you all know, multifocal several optical design have been developed on the market, but the goal is still the same, is to get multiple focal points. And as light rays pass through multiple diffractive surfaces, this may cause energy loss, reduced contrast sensitivity, and increased frequencies of glares and halos. That's the reason why there are some concern in glaucoma patients. This meta-analysis has compared quality of vision between patients implanted with multifocal IOL and patients implanted with monofocal IOL. And as you all know, halos are 3 times more frequent in the multifocal group, glare almost 2 times more frequent, and contrast sensitivity depends on the IOL technology, on the technology of the multifocal IOL. What about glaucoma patients? This is a small cohort of patients as compared 10-2 visual field parameter before and after surgery in 22 patients with multifocal IOL and 15 patients with monofocal IOL. And they show a significant reduction of MD value in the multifocal group on the 10-2 central visual field and no change of the PSD values. And there was no significant difference before or after 6 months post-op, meaning that neuroadaptation had not changed visual field values 6 months after surgery. This other cohort of patients has analyzed defocus curve and contrast sensitivity in AMD patients, preperimetric and perimetric glaucoma patient, and control patient. And they showed that control and perimetric glaucoma patient had no difference of visual performances, but perimetric glaucoma patient and AMD had a significant reduction of defocus curve and contrast sensitivity. Dry eye disease is a concern in case of implantation of a multifocal IOL. And this prospective observational study has included 630 participants with glaucoma or ocular hypertension. And they showed that the ocular surface disease index score that almost a quarter of this cohort of patients had moderate to severe symptoms of dry eye disease. And this score was strongly correlated with the number of hypotensive medication. These all other studies have also shown that signs and symptoms are closely correlated with the number of hypotensive medication. So in case of multifocal IOL implantation and dry eye disease, there is an increased risk of refractive error and patient dissatisfaction. And as dry eye disease is much more frequent in glaucoma patients, this is a concern for this profile of patient. What about patient satisfaction in glaucoma multifocal IOL group? They show that vision-related satisfaction score was significantly higher in controls and preperimetric glaucoma patient as compared with perimetric and glaucoma and AMD patient. The other questions did not exhibit any significant difference between the 4 groups. What about head of IOL and glaucoma? Again, literature is not large on this topic, but this perspective observational study has analyzed the outcome of non-diffractive wavefront shaping IOL, and they showed that 96% of this cohort of patients had a refractive error below within 1 diopter, with an improvement in intermediate visual acuity, and 65% had no glare or halos. It's important to mention that glaucoma patients were at mild stage of the disease. This other cohort of patients has analyzed mild stage of the disease, and this cohort of patients was also stable, and they show similar results with the same type of head of intraocular lens. But they also show a reduction of contrast sensitivity at high spatial frequencies. Interestingly, this large cohort of patients has analyzed the outcome of monofocal plus EDOF intraocular lens at various stages of the disease, at mild, moderate, and severe stage of the disease. And they analyzed visual acuity, visual field parameter, and OCT parameters. And they did not show any significant difference between the two groups for the three categories of glaucoma severity, and a similar improvement in the magnitude of effect. Do we have some recommendation? The French Glaucoma Society and the French Society of Refractive Surgeons have published a recommendation based on a consensus of the two societies. And you can observe here that monofocal plus, and toric IOL were possible to be implanted at all stages of the disease, ocular hypertension, mild stage, moderate, or severe stage of the disease. About non-diffractive wavefront-shaped EDOF IOL, it is considered possible for ocular hypertension and mild stage of the disease, and no risk factors for progression, and less recommended for other stages of the disease. And about diffractive IOL technologies, less recommended in case of ocular hypertension, but it depends on the risk factors for glaucoma progression, less recommended at mild stage of the disease, and with no risk factors for progression, and not recommended for other stage of the disease. In case of combination with glaucoma surgery, in case of internal trabecular surgery, recommendation were the same as for isolated cataract surgery. And in case of blood-forming surgery, toric, non-diffractive EDOF IOL and diffractive IOL were either less recommended or not recommended. So what are the parameters to be considered to conclude on this topic? Glaucoma severity, of course, as a contrast sensitivity, glare, and halos is a concern in glaucoma patient. Locations of visual field effects, central or peripheral, of course. The risk of glaucoma progression, as we all know that our glaucoma patients are going to live 2 or 3 decades of the disease, and this can impair visual performances with time. The particular case of eye myopia and glaucoma, myopia induced can impair contrast sensitivity, glaucoma again, and some premium IOL can also induce this. The type of glaucoma is also important to consider, particularly exfoliation. There is a higher risk of IOL subluxation or dislocation 10 years after cataract surgery. Iris plateau is also a concern, as myopic shift, myopic refractive error is frequent with a more anterior positioning of the intraocular lens as expected before surgery. We also need to consider the risk of filtering blood-forming surgery with more risk of IOL decentration or astigmatism change. Patient quality of life and combined or isolated surgery are also important parameters to be considered. Thank you very much for your invitation.
Okay, thank you very much, Cedric. It was really a nice talk. And now we are going to attend the presentation of Conrad Larriel from Saudi Arabia, and he will talk about how to manage complex cataracts in patients with glaucoma. Thank you, Conrad, and you are the next.
I want to thank Dr. Jorge Leo and Dr. Martinez de la Casa for inviting me to participate in this prestigious meeting. I'm going to talk about the management of complex cataract in glaucoma patients. These are my financial disclosure non-related to this presentation. And the first thing we should talk about is about meiosis. When we talk about meiosis and taking into consideration that cataract surgery nowadays is the most successful surgery in our patients, has a very high expectation, meiosis will affect our visualization, and the lack of visualization will increase the risk of complications, and our glaucoma patients has a high rate of having meiosis. Probably the best and easiest way to use during meiosis is the stretching technique. The problem is that this technique will break the sphincter of the iris, and then the iris will behave erratically. There are some other devices that we can use for keeping the mydriasis during the whole surgery, as the soft material or the wire material, as in these cases. In this study, both devices were analyzed, and it could be seen in the same patient, one eye with Malugin ring, one eye with the soft material, that 11% of these patients that had the soft material has distortion of the pupil in the postop, while half of the patients that use Malugin has the presence of this distortion in the iris. Pseudoexfoliation is a condition that not only produces glaucoma, it also makes the surgery difficult, but can have complications in long terms. And one of these main conditions that the pseudoexfoliation produces is the sonular weakness. This sonular weakness can be seen during the evaluation under the slit lamp. With normal pupil, we can see an increase in depth of the anterior chamber, also a close angle in this region. It's very common because of the movement of the lens anteriorly, phacodonesis, iridodonesis. And when we are doing the exam under mydriatic pupil, the decentralization of the lens, as well as the direct visualization of the sonula. Intraoperative signs are like falls, tendency of the lens to move or tilt, and in my case, the best way of face this pseudoexfoliation cases for surgery is to lower the infusion pressure, lower the aspiration flow rate, lower the vacuum, and increase the ultrasound power. The main idea is to avoid the stretching over the sonula. In case that we see this erratic movement of the lens, another tool that is very useful is the use of the CTRs. The best is to use it as soon as you have a space enough to introduce. And in some of the cases, the stabilization and mydriasis can be obtained by the use of hooks, iris hooks, that not only can be used for the pupil, but also to stabilize the back. In this case, the capsule is really anomalous, and we need to cut with micro-sized scissors in order to avoid tractions in any direction. And then the phacoemulsification is better to do it in the central area, avoiding all traction in any sense. When we face patients that has a previous filtration surgery, doing a cataract surgery will increase the possibilities of failure of this filtration surgery. The best is to approach to these cases by doing the incisions away of the filtration area and doing a revision of the trabeculectomy or the deep sclerectomy, whatever the filtration surgery was, internally with a spatula or by doing a nuclear. Phacolytic condition of the lens, it's a process in which the cortex becomes liquefied, and this hard nucleus is floating inside of that, floating inside of those cortical material that are liquid. These lenses are hard. These lenses are what we used to call the Morganian type of cataract and produce an inflammatory process. As you can see here in the anterior chamber, when we do the application of lidocaine, how clear these materials are. These nucleus are sometimes not that big, but they are very hard, and in some occasions it's better to try to remove by extracapsular cataract extraction if you're confident of. The tension in this back can be so high that just a small puncture can produce this condition that is called Argentinian flag. The best is to progress the capsulorhexis at one half and the other half, avoiding the extension. Sometimes these bags and its capsular tension rings to stabilize or hooks, as we show. To talk about the last conditions we have to treat is probably the most challenge is the nanophthalmic eye. Nanophthalmic eye are eyes that have an axial length below 20, below 2 standard deviation of the average. Usually they don't have a space, as you can see in this UVM, peripheral anterior synechias with blocked angle in 360 degrees, so the glaucoma is hardly controlled. Posterior macular folds that makes the vision is usually not better than 20/40. And after surgery, we can get more space in anterior chamber. That usually this is, in one way, is a way of controlling the glaucoma. As in this case, that the patient went from the needs of 3 drops down to only 1 medication and 2 years of follow-up. Of course, we are always scared of the uveal effusion syndrome. That is a condition that can be present during the surgery. There is different ways of treating it, but for example, the sclerotomies as described in my hands, Jim and Anderson and the blood hoods are my preferred techniques. And in this case, that I'm going to do a Jim and Anderson sclerotomies, I prefer to do it before the cataract surgery. It's like any flap that we do for a filtration surgery. It has to be deep. You have to see the uvea, and the best is leave it without suture. You have to leave it alone. Then you can proceed with the cataract. Why doing before the cataract surgery? Because the eye has more tone, so it's easier to do it. In these other conditions, the eyes do not have enough space, pressure is high, do not respond to the pre-op mannitol or the topical drops, and it's better to do a central vitrectomy in order to generate more space and make the cataract surgery straightforward, like in this case, until we do the revision. In this particular case, when we did the revision, we could see this uveal effusion syndrome, that it was present, and the way of face it is by doing the sclerotomies in the block force way, which is this one. You can see how thick the sclera is. You have to reach the uvea, and once the way to avoid that the flap will close is to do a suture like the Ahmed Mustafa type. Next day, retina is absolutely flat. So, in summary, lack of visualization could affect the outcome of our cataract surgery. Plan in advance, be aware of what is available, and you might need study the pre-op very well, treat the patient as needed in case of non-ophthalmos, prepare your team, and make them involved for possible complications. Thank you very much.
Thank you very much, Conrad, for this very nice case series with very complex cataract to be operated and done successfully. So congratulations. And now we have the honor to have this distinguished group of panel, Miguel Teus, Lucía Real, María Gesa, and Elena Redondo. All of them will be with the speakers and with their own opinions about this topic, because it's a continuous concern, how to manage glaucoma the moment of cataract surgery. We have the cataract surgery performed in younger ages. Sometimes these patients have already glaucoma, and of course the expectation of life is very long, and to try to solve the problem of glaucoma in terms of dependence of medication seems to be convenient. So I think that the number one, José María Martínez de la Casa, is my co-chairperson. What do you think, José María, how we should approach these patients that have medication, they have cataract surgery? Might be that some of them are early cataracts, but with long life expectation, they face complications because the toxicity of the medication, the lack of compliance and the use of medication, and there's so many problems related to the medical management of glaucoma.
Yeah, hello, Jorge, and thank you for inviting me again to co-chair with you this session. And I think it's, as Leon said, the cataract is a window of opportunity to reduce the burden of medication, to reduce the ocular surface adverse events. So I think that always that it's possible, that is a good option to combine the cataract surgery with a minimal invasive glaucoma surgery to reduce the burden of medication, to reduce the ocular surface, and to increase the compliance of the patient. So I don't think, what do you think, what do the rest of the panel think about that? How often do you combine the cataract surgery with a mixed procedure to reduce the burden of medication, to reduce the ocular adverse event, and to increase compliance?
Yeah, probably, I think Elena Redondo, you are on the screen. Well, what is your first approach when you face this type of patient? You will perform cataract surgery and you associate any mixed procedure and you do that. Which one is the first choice for you?
I'm really considering adding a mixed procedure only in mild glaucomas, in patients controlled or with 1 or 2 drops maximum, no more than that, and when the glaucoma is stabilized. So I usually perform cataract and ELT, that's the mixed procedure I mostly use. But if the patient has more advanced glaucoma, or the patient is on 3 drops, or his visual field is not mild glaucoma, but moderate to advanced glaucoma, I prefer to go for a combined procedure with a deep sclerectomy. That's what I usually do.
Yeah, of course.
Very good. And Miguel, what is your approach?
Hi, can you hear me?
Yeah.
Can you hear me? Yeah, okay. Well, my personal approach is I tend to use And stenting, the eye stent is my favorite one in almost every case of combination of glaucoma and cataract, even ocular hypertension and cataract. The only patients I don't perform a mix is advanced glaucoma with not very good control IOP. I prefer to do a combined filter surgery in these cases. But in all the rest, if the patient accepts, I tend to do an eye stent implantation.
So stent is your choice. Do you use also the excimer laser technology, like the Helios?
No. I think that devices that tend to occupy space in the operating theater, well, it's a
Okay, may I ask a question?
Yeah. I think yes, of course. You can elevate your hand with the chat, and we can see you that you want to enter. Yes, Jose Maria.
Yes, because we usually use the minimal invasive glaucoma surgery in mild glaucomas, but Leon raised up another possible indication as the bridge therapy. If you have to combine the cataract surgery with a minimal invasive glaucoma surgery, or you can combine the cataract surgery with a minimal invasive glaucoma surgery to prepare the eye for a filtering surgery. Do you use the minimal invasive glaucoma surgery in this scenario, for example, Conrad? Like a bridge?
Yes, I like the idea that Leon was also mentioning. You know, sometimes
We don't have connection now.
surgery plus I stent before going for a filtration.
No.
Did you hear me?
Yes, perfect. Thank you. And do you have any preference in terms of which kind of minimal invasive glaucoma surgery do you use in your patients with glaucoma? Because usually there are mild cases. So do you prefer a safe procedure over the efficacy, or do you think there are more of them as the same? So what is your...
Well, regarding angular surgery, I have three options. So among them are eye stents, that now we have also the Infinity, Cahook dual blade, and ABIC. These are basically the three options I have. In my experience in this area, they more or less work in the same way. So I think that it will depend a little bit more on the availability. It's true that in my hands, Cahook dual blade gives me more risk of hyphema. So I will prefer over the Cahook, I will prefer the eye stents.
And Lucia, for example?
So eye stent seems to be the preferred practice. Fine. And about intraocular lenses, there was a very nice presentation from Dr. Cedric Schweitzer about the use of lenses. I think that there is a general agreement that multifocal lenses, in cases in which you have already visual field tests affected by glaucoma, are never indicated. Is there consensus on that?
I don't use it.
Yeah, I believe.
What about it of? Has a very broad spectrum. Those that have a central optical artifact definitely are much more selective, probably, and they need a larger amount of visual potential. While the others, like the iHands or the Vista, they don't need this visual potential as much. So it might be that these EDOF lenses, in which you try to accomplish an improvement, not to relieve near vision spectacles, definitely could have a role. Well, what is your opinion about that? Jose Maria first.
I think mainly my patients with glaucoma use an enhanced monofocal because it doesn't affect the contrast sensitivity or but also I do use EDOF intraocular lenses in patients with mild glaucoma. I have no problems to use it in patients with controlled glaucoma. Multifocal, it's another problem, because I don't like to use in patients with glaucoma, even in patients with moderate or advanced glaucoma, but also in early glaucomas with some damage in the visual field, some degree of contrast sensitivity alteration. I don't want to use multifocal IOLs. So I think the Enhance and EDOF can be used in mainly most of the mild, even moderate glaucomas.
And Frederick Schweitzer, you did the presentation. So which is the lens that you use more in your glaucoma patients without visual field changes? Or initial visual field changes? Now, without the glaucoma, they could be perimetric glaucoma, but in this case, you don't detect a real damage in the visual field, but you know that because the optic nerve analysis, you have a glaucoma combined with a high IOP. Which lens do you use as far as these patients will have an evolution, and you know that they should be obviously with an adequate contrastivity and good function? But today, the visual demands of our patients are very much, and they many times are asking us to use lenses that probably are not that much indicated. So this is why my question to you: how do you approach your initial indication for intraocular lens in patients in which you have the evidence of early glaucoma?
First, I would say that there is a kind of bet when you propose premium IOL to your patients, because the main concern is progression. And of course, if your patient is at high risk to have a progression with time, it's better not to propose a premium IOL, but only monofocal or monofocal plus IOL. I would say that in case of ocular hypertension with a very low risk of conversion to glaucoma, you can propose almost all the IOL we have on the market, all technologies, I would say. But in case of mild stage, EDOF wavefront shaping IOL would be preferred. Diffractive IOL have a high risk to have a decrease in contrast sensitivity, and as glaucoma patients already have a decrease in contrast sensitivity, even at earlier stage of the disease, I would not recommend to use diffractive technology for this kind of patients.
Very good. And Lucia Real is my colleague in Alicante. When you have a patient that has already a filtrating surgery that is successful, and you perform cataract surgery, you know that you have risk to lose the control of the glaucoma. So what is your approach in these cases?
Well, in these cases, I always explain the patient that that's a possibility. If the surgery is working, that I try to do a slow motion cataract surgery to try to use less energy, prepare the eye, put pre-op IOP drops and treat the inflammation, because we know that the risk of failure of the surgery is going to be in relation with the risk to have more inflammation after the surgery. So I try to manage that two things: the preoperatory, intraoperatory slow motion, and try to use as less energy as possible, and the postoperatory control of the inflammation.
Yeah, if the patient has borderline control, for instance, glaucoma has a filtering surgery, has a bleb, but is with one or two molecules, in order to have acceptable levels of IOP, what do you do?
Myself?
Yes.
That I did, that I know that I can try to do it better. I mean, a deep sclerectomy, that I know that maybe after surgery I can do a goniotomy or needling, and I can improve the function of the surgery. I'm going to do just the cataract surgery. If it's a patient that is new for me or has a previous surgery and is with two meds, and the IOP maybe is not in the best objective IOP that I want, I'm thinking that maybe that surgery is not working anymore. And in these cases, depending on the stage of the glaucoma and the status of the patient, in these cases, sometimes I think to combine with mixed surgery, and I know that is a controversial part, or to do a second filtration surgery, depending, of course, of the patient. But it's two possibilities that nowadays I'm thinking that I can do.
Maria is our colleague as well. Do you have any question? Because you and me, we are much more in anterior segment cornea cataract refractive. Glaucoma for us is a secondary specialty because we use it, but we are not in the field of glaucoma that much. Do you have any question for this distinguished panel of speakers? We are privileged to have that many glaucoma specialists with us.
No.
You are muted.
Can you hear me?
Okay.
Okay, sorry. I would like to thank you, everybody, and say congratulations because of all the talks. And I would like to ask about pseudoexfoliation. If you consider to assess the surgery whenever you diagnose it, in order to prevent all the complications, not only in the surgery, more also after the surgery. I don't know if you, for example, we have a patient, mild cataract, good vision, but you diagnose the pseudoexfoliation. Do you recommend us to do the surgery, the cataract surgery?
I can give my opinion regarding this. The point with pseudoexfoliation is tricky because pseudoexfoliation has, as you well mentioned, early post-op and late post-op complications. The early ones that can happen during the surgery, yes, you probably can avoid if you do an early surgery. It's not the same thing to do, you know, a +3 type cataract than a +2. So, but the patient has to be convinced about it because complications can happen in any moment, even in the best hands, even in the hands of Professor Aliot, that probably are the best ones around. I will suggest to have the cataract surgery early, better than late. And then come some technical issues regarding the surgery. I have seen patients that 10 years after the surgery, they have a dislocation of the whole complex, lens, CTR, and back.
Yeah, and also there is some evidence that the effect on the intraocular pressure can be higher if you do an early cataract extraction, but if you have a more advanced cataract and you do the surgery in a more advanced cataract. Leon, what do you think about that?
Sorry, repeat the question again, Jose. Sorry.
No, I see. We are talking about the right moment to do the cataract surgery in a patient with pseudoexfoliation. So, are you more in the way of doing early cataract surgery or in a more?
Oh yeah, without a doubt. I'm going to go as far as say that any glaucoma patient, I try to make them pseudophakic if we can. You know, it's a little bit controversial, but to be honest, I think that I'm not a fan of combined surgery in terms of phaco traps. So I think a pseudophakic patient, whether it's narrow angle or an open angle, for us is easier to handle. So I'm not going to take a clear lens out for no reason, but if they're pseudo-exfoliative, I would be keen to take the cataract out earlier. No one wants to do a rock of a cataract when it's just dangling around on 3 sonules, like Conrad said. So yeah, I would try to persuade them for an earlier cataract surgery combined with some mix.
Leon, I have a question for you, because this is an important topic. Pseudoexfoliation is frequent, especially in some countries. And do you really think that early cataract surgery makes any effect in the glaucoma in these cases? I think that is better for the surgeon, but for the patient it's the same. I don't think that early surgery does any difference for the patients.
Well, it depends on what you mean by difference. I mean, again, I'm not saying that taking cataract out on a patient who's got no symptoms. But if they do have a bit of symptoms, then I think earlier cataract surgery rather than wait, because you do get the pressure lowering effect from cataract. You will get more when you combine it with mix. And if you at an earlier journey of the glaucoma, you can just lower the pressure by a bit, then they will end up in a much different place than waiting for them much further down the line. So it's like if you turn 2 degrees and go 5 miles down the road, you're going to end up much more different. So I think that glaucoma is only young ones. So I think when they're early, if you can lower the pressure a little bit with your cataract surgery combined with mix, you will end up with a very different place. And I think we've got data to support that.
You can also see that
we have a different...
Sorry, Dr. Alio, I just want to add something to Leon. It's true that when you do an early cataract surgery, even though years after you can see some of this pseudoexfoliative material that deposit over the lens. So it's something that we have to be aware. It doesn't mean that when we remove the cataract early, as Leon said very well, it's good for the patient, it's good for the surgeon in that way, but it doesn't mean that we cure the pseudoexfoliation.
No.
It can appear the pseudoexfoliative material. So we have to be aware that it can develop later on a pseudoexfoliative glaucoma.
Yeah, exactly. Well, I think that we have this topic, pseudoexfoliation, for the next year, because it's a very strong topic. It affects the most difficult cases in cataract surgery, and I think that cannot be in the debate because we are over time now. But definitely this is, in my opinion, an open topic. Pseudoexfoliation is one of the unsolved problems today in terms of decision-making process for the cataract and for the glaucoma surgeon, and together probably we can get next year a better perspective of how to manage these cases. Do you have anything else to say, Jose Maria, before closing the session?
No, I think also congratulate all the speakers for their presentation. I think it's three very important topics for the patient with cataract and glaucoma, and I think it's quite clear the benefit of adding the triaqueous mix to the cataract surgery to decrease the intraocular pressure. I think it's also very clear which kind of IOLs do we have to use in patients with glaucoma, and also how to avoid the complications that Conrad has shown very well, how to avoid and how to manage the small pupils and all the possible complications that we can have in these patients with glaucoma and cataract. So thank you, all you three. Thank you, the panel, for participating in the debate. And thank you, Jorge, as always, for organizing these kind of meetings.
Well, thank you very much. I think that we are learning a lot, at least myself, and I feel very thankful. So thank you very much, and the session is closed. Thank you.